thank you all for having me here. Great to see Philippe, who I worked with on the book, Ankle Injuries in Football. Of course, Peter, all your age, but a big friend of mine. And some familiar faces and some friends that I saw already. So thank you for having me. You know, all these Dutch guys that you see, I don't know if they told you the truth, just to recuperate a little bit. This is our flag. It's all about the orange, but the flag is really red, white, and blue. It's the only reason that, because in our battles at the sea, that the orange was not visible enough. So that turned into red. So that's an easy thing. We always had a queen, now we have King Willy. And then the most famous Dutch guy is football players. I don't know what that says about our country. We like to speed skate. When there's ice, we're on the ice. That tells everything about the Dutch. We do that just when the sun is out. We go with 12 million out of 40 million. We go to the beach. When the ice is out, we're with 12 million people on the ice. So what are we good at? Medicine, of course. That's why we got all these doctors here. But the thing we're also really good at is to conquer the battles with the water. So we have 16,000 kilometers of dikes. And we've, I think, most famous for our water projects. So what about me? I'm just practicing here to be in the Dutch team. As you can see, this is the first club, Rooms-Katholieke Ambische Sportvereniging. Just before we made the cut for MVV. This is where I come from. Trajectum ad Mozum is Maastricht, so I'm almost a Belgian guy. I tried to get to the Belgians and to the good side of the country, but didn't succeed yet. So then in the 90s I went to Amsterdam just to have a look at the country that has these beautiful sites and that has the ongoing battle with Rotterdam of Voorwaarts. And we'll see who comes out on top. So this is my student time, lots of sports there. And then I went to Amsterdam University to do orthopedics. And I think this is the picture that has both in it. So René Marty and Nick van Dijk. And René Marty was really my first inspiration in being a doctor. Because he was a very personal doctor who was not afraid to drink a wine after the surgery with the patient. And all the patients loved him. So that's the thing that I liked about him. Then I did the PhD, as was mentioned already. Went to Switzerland a few years. Quirine was born there, my daughter. And we were, from our garden, we could see the helicopters fly in the trauma. So it was quite an exciting year there, 2 years. Then I went back to Amsterdam, and that's where currently we stand. So great to be here and talk to you about talar OCDs. I think there's a lot to be said, and I will leave some things out, and feel free to interrupt if you really have a question. I think Robert told me that at the end we have time for discussion, so that'll also be good. So how do we get the talar OCD? This is not the way to get it, but it's a difficult injury. So most of the ankle troubles, and this will be in super slow-mo so you can have a closer look, they start with a simple sprain. So probably there's no such thing as a simple sprain. And we'll go to anatomy in a short while. As you can see, it looked like nothing, but it's probably the start of a lot of problems. If you list it, you see pain in your ankle, there's only a small number of ankle injuries possible. With the ligament injuries, peroneal tendon problems, impingement problems on the anterior side and the posterior side and the syndesmotic side, chronic syndesmotic pain, stress fractures, original fractures. Today we're only going to talk about talar OCD. So first talk you through the anatomy a little bit. Start at the medial side. You can follow the orange of the green dots here. I think this is probably going to work. Okay, sorry. Oh, that's it. Yeah, that's it. Okay, thanks. So this is how it goes. Tibial slip, lateral side, then the overview with some names in it. So you can imagine if you go back to this picture of this girl having a simple ankle distortion, that you can damage quite some structures. And also you can visualize that you can have a lot of damage on the cartilage on the medial side of the talar dome. because it's just a big trauma, and there's no proprioception to take care of that. If you look at the cartilage of a child, it even looks more vulnerable. So, special thanks to Paul. He emphasized, okay, if we look at ankles of the deceased, then we probably see a lot of osteochondral defects. And some of them were painful during the years and some weren't. This is how it looks like if you have a status after a condyle fracture. Okay, so the first part of the talk will be to give you the best evidence that we currently have on the operative treatment of osteochondral defects. All treatments can start with conservative treatment. In fact, in the reviews that we did ourselves, we see that all the operative treatment modalities have a better result after initial conservative treatment. So conservative treatment at all ages is always the best first option. It's where it starts. What we also see is that conservative treatment alone in a symptomatic osteochondral defect on the talus has a success rate of far below 50%. It's around 25 to 30%. So it's probably not enough, but it's good to start with. Probably to the supertentorial way, it helps getting better results with surgery. So first, debridement and drilling. It's the easy part. So this is the anteromedial distal tibial side. This is the loose cartilage. What we do is identify it with a hook, take all the pieces away, make some little drill holes, and see this blood clot form into the fibrocartilage. Then we have all the AC and Macy techniques and the cartilage substitutes. That's also a whole group. So I think it's a battle between the debridement and drilling, the microfracturing, and cartilage substitutes. So what is the best practice then at this point in time, or maybe yesterday? If you look at what is out there on evidence in the literature, then you have there are three systematic reviews published the last years, and you can go over them point by point and see what good points and what bad points are in there. So this is a study conducted in Amsterdam. I think it's a fairly good search. They included all treatments and only studies or patient series who had a higher number than 10 patients, 10 participants, and there was a quality assessment of the studies done. However, there were no RCTs, not even case control series, and there was no consistent follow-up. So it's a systematic review of what is out there, although the level of the evidence is not that high. What you can see is that the success rate of the bone marrow stimulation is 84%. Then the review of published in the arthroscopy. I think the major point there is that they had a fairly limited search because they included only studies that use the AOFAS as an outcome score. It's a good score, the AOFAS, but it's not validated for assessment of treatment of talar OCDs as such. So there's a fairly limited amount of studies included in this review. BMS success 80%. So then the Niemeyer and Zuidkamp review, actually I think an excellent review with only one real negative point is that they included the series from Bologna 4 times in the same review because they were at different dots in time. And that explains the high range here, 50 to 100%. So that's a very strange range to make a conclusion. Finally, they had 90% success of the AC here. Then, what results do stand the test of time? Actually, there's only one study, and it's from our own center, and we came out 76% of success rate after 8 to 20 years of the simple microfracturing for treatment of talar OCDs. It was published in the GBGS. I think it's an old-fashioned retrospective series, and it is really level 4, almost level 5 evidence, because all the outcomes were scored by the doctors themselves, and it could be that the success rate on the long term with the modern ways of scoring would be a little bit lower. Despite this, I would say, okay, if you look at what is the evidence here now, then for today, I would say the BMS, the microfracturing, is a one-stage technique, has a high success rate on the short term and a fair success rate at the long term, has a very short rehab, has low morbidity, and you can fill the gap with fibrocartilage instead of hyaline cartilage, but is a good treatment for your patients. So that will be the best practice to start off with. But that is not the end of the story, because we need room for improvement. We want to improve and we want to do better for our patients. So how can we improve? First of all, how can we improve the microfracturing treatment? We could make less collateral damage. We could aim for a complete fill of the defect, treat larger defects, match the hyaline cartilage, and stop the progression of osteoarthritis. That would be good. So how to do that? I'll just emphasize a little bit of our research here. So we could try to improve technique, use PRP maybe, use hyaluronic acid, what about pulse electromagnetic fields, or maybe healing water. So first this, optimized technique. We looked at different techniques described in all the papers that described microfracturing as a treatment for talar OCD, and they all used a certain type of the Stepman microfracturing technique, and there were no major differences there. So in the end, our conclusion was, okay, in the technique that's used, there's not much space for improvement. So we can forget that. So what about hole geometry? Who of the surgeons makes 4 holes? Who of the surgeons makes 6 holes? Who makes 8? How big are the holes? Should they be deeper? All questions that came up in my mind, and we looked at this question in an animal study, and we used Dutch goats to answer these questions, and in the end we looked at the depth and the diameter, and we looked at repair tissue, the osteoid formation, and the structural integrity of the tissue that was formed. And again, we found no difference whatsoever between the number of holes used, the depth, or the diameter. So also, it does not seem to matter what the hole is shaped or looks like and how many holes we make. So probably we only have to break the subchondral plate, and the holes are just there for the surgeon because it has better aesthetics. I don't know that. So we didn't answer that question. What about demineralized bone matrix or the use of PRP? Again, we went to our goat model to look at this, and we found no difference again. Not between the use of demineralized bone matrix to fill up the gap versus no filling of the gap, and also not DBM plus PRP versus DBM. So again, no differences, also not in histology there. So results published in here. What about pulse electromagnetic fields? If you look at that PEMF in the Google, found about 12 million hits. So you can use it for everything, only not for growing hair. So that's the only thing I didn't find. But how would it work? Suppress inflammation, relieve the pain, promote tissue healing through the TGF-beta pathway. So just to shortcut that, we did a randomized clinical trial, double-blind for the researcher and for the patient. Multi-center, we just finished it. This is very preliminary results, so just put it down as no difference. So 34 patients got a PEMF in the after treatment phase, 2 months of pulse electromagnetic fields versus a placebo device that looked exactly the same. And there were no differences between the patient groups there. So that also did not give the improvement that we're so much looking for. What about hyaluronic acid? I think I quote an animal study here that shows potential beneficial effect at short term. There's also an RCT published by the Turkish group. It is a disputable RCT, as in it's a good evidence because it's a nice patient series, but they have a group of 17 and a group of 34 patients. So it's a strange randomization. They found at 1 year post-surgery a possible beneficial effect of the use of hyaluronic acid as well. I think more evidence needs to come out of this. So what about healing water? I think it's a good term, because everybody thinks, why healing water? What's this guy? He's an academic. What is he talking about? So healing water got us a lot of grants, because of the name only, I think. And what it means is that instead of using microfracturing probe, or instead of using K-wires, you use water to make holes in the bone. So would that be possible? And why would you want to do that? You could want to do that because in the different joints, not even only in the ankle joint, but in the different joints, most of the osteochondral defects are at a difficult spot. So it's not easy to get in this surrounding without making damage at a certain point to the cartilage on the contralateral side of the joint. Certainly in former years when we used the K-wires to microfracture, thermal damage to the cartilage and the surrounding tissues, and to get all the holes perpendicular is also be a difficult task. So if you want to do this with water, what would be the potential problems? I think the potential problems would be to get at the right spot, to navigate to the right spot, to act at the counter forces, to watch the scattering of the water, and to control the depth, as well as to get the right amount of water at the right spot. I'm not smart enough for that, you can imagine that. But potential advantages would obviously be that it's contactless, always sharp, simultaneous, fast, drilling around the corner, everything is possible. And we need a team for that. So the Technical University of Delft and the engineers there, they helped me in this project. So during the experiments, the last 2 years, these were the problems to conquer. And yeah, this is where the water comes from the nozzles. You should have the adjustable jet time. The pulsation should be just right to improve the impact. All these spots. I think this says it all. The engineers managed to get the problems conquered. And this is our experimental setup. So what we are able to do now is to make the right holes, to control the diameter and the depth of the holes, although the bone is a very difficult structure. It's not like concrete that it has the same consistency everywhere. Bone is different because subchondral plate is much tougher than metaphysis, and this is how it looks like. So these are the things that we're currently looking at, and as I speak, we're doing a goat study testing the first device for controlled drilling of water in the subchondral plate. That's something for the future, but we're working on that. So then in the after treatment, what do we know about the after treatment? I think the after treatment is, has been underestimated in my training as an orthopedic surgeon, and nowadays we work much better, multidisciplinary, and we just attack the problem of the patient. And it's together with the sports medicine physicians, together with the physiotherapists and the movement scientists, and we make a difference doing medicine like that and just looking at the problem and not only performing the operation. I think performing a perfect operation, that's a task we should always do, but to consider the right after treatment is also very important. So what is out there in after treatment country looking at the best evidence? Not much. What do we know? This is a study conducted in Amsterdam. I'm not proud to say that I think it doesn't really bring anything new. Just rounds up very old ideas, as in, okay, what is happening in the inflammatory phase? What is happening in the remodeling phase? It's nice to have a thought that the fibrocartilage will turn into hyaline cartilage at week 8 to 12, but there's not much evidence to support this. It's what we hope for. But after the microfracturing, we didn't find that much hyaline cartilage, so I don't know if this is true. In theory, it's a nice list, and it's good to have the right knowledge about that, but I think there is more to the after treatment than that's only listed in here. Then these are very structurized things. Normal walking, yes. Running on even ground, no contact sports, and then contact sports. Very normal list, almost amateuristic, what's out there in literature. So I would say open up as being the Aspire physical therapy team to make this much better. I think the key is in this, like in medicine, in all patients do not fit guidelines. So every patient should have a list of things they should learn in their after treatment before they can return to their sport or their activity, but it should be personalized. Personalized after treatment. So it's not time-wise, but you have to get things done. So somebody who has a deep ankle pain and has been having pain for 3.5 years before he or she dared to have surgery and is in the current after treatment, is a lot different and after an acute osteochondral talar fracture that was fixed straight away. Because the awareness and the proprioceptions and the balance in this last patient will be much better than in the first patient. See, he or she will have a 3.5 years deficit there. So it's very important to realize these things in the workup and in the expectation management of the patient. Not to go too fast and not to forget to make steps. I think this is a small list of things that I find important when we work in our team. So, okay. With this rounded up, because it's 25 minutes and Rob told me well, about 30 minutes will be nice. I think it's another point would be interesting to emphasize. So you're all going to be patients, and I think it's only 8:25 in the morning, so it's quite early to be a patient, but think of yourself as being the person you are yourself, but with deep ankle pain. And the deep ankle pain has led to the fact that you're not doing your sports anymore. So you have had your conservative treatment already. And you're also having difficulty to bike to work, at least for the Dutch people that I met this morning, and the Belgians. And you cannot, as a surgeon, stand on your feet during an operation of more than 30 minutes, because then really the pain is getting to you. You have this catching and locking sensation in your left ankle, and it's really painful. And then you walk into the room with Philippe or Peter, and they tell you, well, you have also a osteochondral defect of your talus. So that matches your complaints, because you have had complaints for 2.5 years. You've done actually everything in the conservative world that you could do. You've done your physiotherapy, and you're very strong. You have good control of your feet muscles, and the calf muscle is quite big. So you have good strength. And on your physical examination, there's this typical pain on palpation when the foot and plantar flexion from the medial side, straight on the spot, that gives you this really aching pain. It's like a toothache. Pooh. So you're sweating already a little bit after the physical, like all the patients do if you hurt them. And this is you, walking into my room now. And I'm your doctor. And this is the CT scan. So yeah, it's a clear-cut case. Even a child can see that this is a hole. So you have an osteochondral defect of the talus. So what do you want me to do? You want me to make the hole bigger and make some microfracturing in there. And then after a year it looks like this. But I say, okay, you still have pain. I'm sorry. I did the right job. Or maybe this case. Again, it's your ankle. And you have deep ankle pain, just like emphasized before. So I did this, made the hole bigger and made some microfracturing there. And after you have this and you have pain. Still the same pain, actually a little bit more, doctor, a little bit more. Sorry to say, colleague, but you didn't really help me out here. So what did I do here? I looked at Hippocrates and I spit in his face, because I made more damage than the patient had before he walked into the room. That is not a real nice thing to say. So who of you would choose for our current gold standard for treatment of the talar OCD? All hands rise. Who would like a microfracturing for his or her talar OCD? I think you're all asleep, or something else. So we emphasize on that. So one? Okay. Maybe one or two will try. And the rest, what will you do? Just have pain and go home?
No, microfracture and something to improve the microfracture.
Okay. So microfracture has something to improve. That will be okay.
We have a yellow cast here, so you will do with yellow cast.
That's good. I don't know. Maybe I have an alternative. So we could have an alternative. I think the nice thing to realize is that as orthopedic surgeons, sometimes we do operations that we don't really support when we would have the problem ourselves. That cannot be the truth. So that is the thing I would get to. So what would be another advantage of another treatment? For example, fixation. Call it lift, trill, fill, fix. You would have preservation of the cartilage that is still there. You would have a normal congruency of the joint, just an anatomic joint. You could treat defects of all sizes. In fact, technically it's much easier if you have big defects. And after that, you could still do a microfracturing with or without the yellow cover. So everything would be possible. If you would do it arthroscopically, you wouldn't need medial malleolar osteotomy. You would have less pain, less stiffness, and a quicker rehab. So let's look at this. If I'm in a room with surgeons, I'll ask, okay, so what is this? It's a fracture, so I'll give it to the rest. Probably everybody will see this is a fracture. So what we do with fractures? We fix fractures. That's what we're born for. It's a fracture, fix it. That's what we want. So let's look at these osteochondral defects. And you would have a fixation of the fracture. You would call it the lift, drill, fill, fix. Because it's a zone that's in there. You would need to lift it like the hood of a motor car. Then you have to debride both fracture sides. And then you have to fill it a little bit because it's like a sandwich, you know. There has to be a cover inside just to have a good bite. And then you have to give the right compression. So both you make vitality, you add cancellous bone, and you make compression, just like a fracture treatment. Just have a look in some slides how this looks like. So this is me. This is the beaver knife that one of the nurses came up with. Cuts on both sides. You can go nicely around the corner. You can see that at this anterolateral corner, this is just the case that you saw before. Let's go back. You can see that the cartilage is thinner already over there, and that's what you can see back here. So this would be a case where the cartilage is not even that good anymore, but it's still better than just taking it out, I would say. So first you cut it, then you lift it, and you can see that the cartilage layer is not that thick anymore, so it's 1.5 millimeters, but it's still there. And the fracture fragment, so it's in fact an interarticular fracture, you can just lift that. Then you can drill it on both sides, or debride it with a curette, so both sides of the fractures are vitalized. And you can fill it with cancellous bone from the distal tibia, just in front of you to take out, and then you fix it. So you can use absorbable screws, whatever screws you want. Didn't have a disclosure yet for this. So this is a newer portion of the slides. And on the bottom here, you will see the bigger pictures. So we walk it through from this side so you can see the whole procedure. Anteromedial distal tibia. After we have removed the osteophytes, always overlaying there in the athletes, and so you have the cancellous bone in front of you. This is the situation with some soft tissue distraction, and already you can see a soft spot here. So the dans gondral. So this is the site we should be. You should know where to go before that on the planning, but you can check this during arthroscopy with the arthroscopic hook. Again, use of the beaver knife, then the small Swiss chisel, that's the sharpest one we have in the hospital. Lift the fragment, and in this case you can see this is really the cartilage we're looking for. So we don't need to take this out, put it in a lab, and come back with cartilage number B, because we have cartilage number A already inside. So we just keep it there and use it. So the curette to vascularize both fracture sites, then with the chisel you take the bone, the grasper to put it in, and then the fixation. This is how it goes. Just to show you on video. Again, it's a different case, but it's an anteromedial distal tibial site. You can see here with the hook where the cartilage dances a little bit. Then you can see the use of the beaver knife. It's always a little bit exciting to cut into the cartilage. But how exciting has it been all these years that we just took it out? Then you lift it. You can see that the cartilage is still in good shape here. And I can't do it without making any damage. It's just like fracture surgery. So you make as less damage lifting as virtually possible. You can use the distal tibial side not to sublux too far. take the cancellous bone, use the grasper to do that. Then you do a little bit more plantar flexion and put the bone fragment in. And you nicely fill the gap until you have the right containment. After you've achieved the right containment, you can use dorsal flexion just to put that. You can see that I fixed the fragment with a hook as well during the drilling, not to sublux or to rotate the fragment too much. And this is the containment. So this is what I'm aiming at. Could be an idea for the future. This was one of the first patients. It's now five years ago, and I was really surprised with this. You know, you can see the spot where we put the screw, but there's really, this is a hole, and this is a normal ankle again. So I checked this with Michael Reiling, who helped me with the presentation, maybe 4 or 5 times, because I couldn't really believe that this was happening. That's completely different than we ever had with microfracturing treatments. So we published this, and what we saw, and this is not so important, you know, because at the moment this is the first 10 patients, and it really looked like, or this is the gold. I'm still very happy with the results. I don't look at the patients myself unless there's a problem for the first year after the treatment. So they are not influenced by me being in the room with any of these outcome measurements. So it's only the researchers that do that, and if they think there's a problem, and there's been 2 cases of that, of impingement, anterior impingement, that caused some troubles. So I went in there and got a treatment for that. Other than that, the results are fairly well. So what about CT scans? We make a CT scan 1 year post-op. And then I thought it was also quite convincing that you could see that this can go through that. And this is where the screw's been. So the screw dissolves itself in the end. This is a big fragment, so technically much easier. What happens with a big fracture like this? So this is an osteochondritis dissecans, and he's been living, actually he's a highest level field hockey player in the Netherlands, and from Amsterdam actually, and he has just twisted his ankle. So this stable osteochondritis dissecans in the talus has suddenly become unstable. I think then it acts like a loose body. It's a loose piece of bone there. It's like an intra-articular fracture. So you could treat it with just fixing it. So this is how at 1 year post-op his CT looks like. You can see that the gap didn't fill totally yet, but the fracture is fixed. And that is probably why he has no pain anymore and is back playing at the highest level. And that's also something that with the microfracturing treatments, I was always very scared when they went back to sports, because the slightest new ankle sprain would set them back again. And it seems that they have a much stable situation now. Obviously they're not better than we were born, but it's a good thing to add. So we have CT scans of all of these, and as you can see from this to that, it seems that both clinically as well as radiographically proven, we do a good thing here. And if it doesn't work at a certain point in time, all the other treatments that we did so far are still possible. So that's something interesting. Stop shooting and making holes, fix the fractures and build bridges. That would be my message for today. And I thank you as the LDFF, and I thank my team for making this possible. Thank you.